Good afternoon again. I am happy to present with my colleague, Dr. Zuelsdorff, the Social Determinants of Health module. We are very excited about this new addition to UDSv4. And we're going to tell you a little bit about why. So I'll just start off just giving you the 20,000-foot view of why we added the form, and then Megan will go through the form in a bit more detail. So just to level set, and Megan and I have presented on this module many times, so you're probably sick of hearing about it. But we know there are significant gaps in our understanding of ADRD in populations that have been historically under-included in clinical research. These data gaps are a barrier to equitable ADRD science. And in previous versions of the UDS, we really only included questions about race and ethnicity. There was a question about education, obviously, for the cognition, but we really, only sort of focused on minoritized status. And really that only allowed us to look at minoritized status as a risk factor for brain health, including cognitive function and dementia risk. But we know that race and ethnicity are social constructs that shape not only health outcomes, but also eligibility for clinical trials, participation in different components of our studies like imaging, biomarker, autopsy, lumbar puncture, and and so on, and retention in the longitudinal component. So, race and ethnicity really become imprecise proxies for what we should really be measuring if we are really interested in understanding dementia risk across different populations. And so what we thought as a committee and the clinical task force that we should be measuring is social determinants of health. And these are the non-medical factors that influence health outcomes, such as the conditions in the environments where people are born, live, learn, work, play, and age. Healthy People 2030 groups social determinants of health into 5 major domains, and that includes economic stability, social and community context, neighborhood and built environment, healthcare access and quality, education access and quality. So a work group of the clinical task force came together representing a number of centers in our consortium and different populations, different geographies. We came together over several months to establish a module to allow us to collect data on the social conditions of our participants in our centers. And importantly, we wanted to capture individual risk and protective factors that may not be picked up by things like the ADI, which almost all the centers are now collecting the ADI. And as you saw, if you were here on the earlier part of the webinar, you saw that we are collecting the ADI and everyone is now in the demographics form. So we wanted to get information that you couldn't just get from the ADI or other public databases. So this module is not meant to be comprehensive, but we started with the NIA Health Disparities Framework and then thought about what was missing from public databases. And the module we came up with includes these 5 constructs: transportation, financial security, social connections, activities and environment, experiences with the healthcare system, and experiences with discrimination. So just some key points and questions to help you as you start to use the form. How should it be administered? Well, it should be self-administered by the participant, not the co-participant. Or, if someone from the ADRC staff wants to give it directly, administer it directly to the participant, that's okay. The important point is that it is the participant's perspective about these different social conditions, not their co-participant. And it could be given either in person, it could be given remotely, or it can be sent in advance of the visit. This is really not meant to add any additional burden. We just think this information is really important to capture, and we are happy that you will get it any way possible, whatever's easier for your center. And so who should receive the form? Participants who have a CDR less than 1, ideally. So those without cognitive impairment or MCI are okay. Because, you know, once you have dementia, obviously the reliability of some of the questions will be questionable. So, you know, we're asking that you give it to people who don't have cognitive impairment. How long does it take? Based on our pilot testing of older adults without cognitive impairment, it took between 5 to 8 minutes to complete the module. And a little bit longer if you're administering it, you know, closer to the 8-minute mark, but it's not that hard to fill out. And then how often should it be given? It was mandatory for the initial visit, but it can be given every year for those centers who are really motivated and interested in looking at social determinants changes over time. So we're encouraging that you do it every year, but it's certainly not required. We just really want to get it at least one time on every person, and then hopefully you will love it so much you'll keep giving it. So I'm going to turn it over to Megan now to cover utilization and scoring recommendations.
Thank you so much, Dr. Barnes. So yeah, we will just touch on some sort of overview of the utilization and scoring. Mainly this section is also just meant to give you a refresher of what the actual module looks like so that we can get a good Q&A going. So just some key points here in terms of the utilization and scoring overview. So the 5 major constructs that Lisa described, they do in most cases, as you'll see, include a few subconstructs that are drawn from different sources and scales. So like I said, as a refresher on what exactly we mean by that, what the new module looks like, in the coming slides, we'll go through each construct briefly and just show you an example. Notably here, for our purposes today, these are all items that have been used before, right? So sometimes with many thousands of participants, including older participants. We do not anticipate that the difficulty level or the complexity level will be perceived as high by participants. All of the item responses are intended to be recorded individually. So there is some index scoring that can happen at the research question or the study specific level. But for purposes of data entry, for NACC aggregation and sharing, we intend for individual item data to be available. And related to that, not a huge focus today, but I will just touch on some of the different indices that have been created in the past and the calculated variables. To that end, we figured we would mention here that we are working on a manuscript for publication that'll detail this module development process, including citations and references for all of the validation studies for the items that went in here, a review of the empirical utilization, and also just some recommendations for center researchers who might want to use these data. Lisa, sorry to boss you around. Can you move to the next slide? Thank you. So as mentioned, just kind of before we head into the Q&A here, let's just do kind of a refresher on what the module looks like. So the module starts off, as Lisa mentioned, with questions on transportation. We've got 2 items on direct access to a household car or other consistent source of transportation. Speaking to the point about collecting these data across visits, not just at a single visit, these were included based on a committee consensus that these kind of questions could represent a really important marker of an inflection point in the daily activities of our participants, including their retention in our studies, but also all of the other kinds of exposures that we're measuring and interested in as well. The other 4 questions are actually drawn from a validated transportation security index. I've included the site for that here in case anyone wants to dive into it today or sometime in the future. Next slide, Lisa. The next domain is financial stress or financial security. As I mentioned, this is one where there's a few different subconstructs that we have evidence are important to health, including brain health, and they're represented here. So the initial question asks about income directly, and that was actually drawn from early plans for the UDSv4. It's followed by several questions on objective and subjective financial hardship. And they are items that are used in the National Population-Based Health and Retirement Study, as well as in many other cohorts of older adults. Next slide. Okay, so on this next slide, you can see that we also include a couple of really widely used measures of social and economic status. This is a little bit tougher to measure than, say, financial stress or security. The first is the MacArthur ladder, technically the MacArthur scale of subjective social status. This is shown to be a really robust predictor of morbidity, of mortality, of psychological and physical well-being in older adults in the MacArthur aging studies as well as elsewhere. The second set of items, you may recognize these based on kind of committee and center feedback. These are a more inclusive version of the measure of maternal educational attainment, which is, again, it's a really ubiquitous measure of socioeconomic status for participants. Okay, next slide. Thank you. On to the third domain, which is, or construct, which is social connections, activities, and environments. It starts out with questions on loneliness and emotional isolation. We know that this is an area that is getting increasing attention in the ADRD world, and actually these items have long been used in the Rush ADRC protocol. We definitely don't anticipate, based on their experiences, any difficulty with participants answering these. Next slide. There are also several items here covering different domains of an individual's social network and their level of engagement within those domains. And then finally, and these items were also drawn from early plans for the UDSv4, and also we think really likely to be an upstream determinant of some forms of social engagement. This construct includes questions on participants' perceived safety of their home and the neighborhood environment that they're living in. Next slide. Okay, so I think we're on number 4 now. The fourth construct just focuses briefly on healthcare experiences, including healthcare access, which is different than availability or insurance coverage, right? So this construct includes 5 items that were actually drawn, or I've cited here a study on discrimination and healthcare, but they have been used within the Kaiser cohort in several other studies as well. I want to point out here, just because my eye is caught by it, one thing that has changed with the development of this module for NACC specifically is that this category of response, prefer not to answer, has been added for all items. It's not present in the source scales or indices. We don't anticipate that it will sort of increase any confusion on participants' part, but I do think it'll be really interesting to look at as we pilot and we move into the early stages to see if there are any items that participants tend to fill that out, or whether it tends to be a pretty rare response. Next slide. Okay, so the module is going to end with an assessment of everyday experiences of discrimination. This is going to be measured using items drawn from a really widely used measure of perceived discrimination. The first 6 items ask just about the frequency of specific experiences. And then the final 2 items are really important. They ask both about the perceived characteristic of a given participant, covering a really wide array of axes of identity and potential discrimination, as well as the level of distress that the participant associates with the experiences. These items will allow research teams to assess really kind of crucial population-specific aspects of discrimination exposures, including pretty well-documented age period and cohort effects. And I think unless Dr. Barnes wants to add anything, that will wrap us up. We've got all of our committee members on the next page, and I am excited to open it up to some questions that you might have now.
Thanks, Megan.
There are a few questions about, I know it was mentioned not to complete the social determinants of health module for people who have cognitive impairment, but then what if they're not clear what their status is until after the visit? What to do with those data?
Yeah, that's a good point. I mean, at Rush, we give these types of questions to everyone, regardless of cognitive impairment. So, I mean, we could do the same thing and then, just determine whether or not we can use those data. Especially if you give the form before you've actually given the cognitive testing.
Yeah, that's what we tend to do. If there's any form you wouldn't necessarily do, but you don't know up front, just to keep the data, include
Right.
that, and then you can make decisions based on what their CDR is, or if there's other things that make you wonder if it's valid data.
So is this a form we would physically hand to the patient and have them fill out themselves? Yes, this is meant to be self-administered. So hopefully you can print it out. Or I don't know if it's going to be reg, it's a NACC question. Will it be on RegCap or is it going to be on paper?
There'll be a paper version and a RegCap version.
Okay, yeah, but it's self-administered by the participant. Couldn't this training be divided accordingly? That way we focus on the forms that we are responsible to fill out and less time blocked for training.
I think this was this was a general question.
Oh, okay.
Yeah, I'll type it, answer.
Okay. And how do we indicate that we're not submitting the A1a at all due to cognitive impairment? I only see reason codes for remote, not for not completed. Oh, that's a good catch. Catherine, maybe we can add that to the top of the form.
Yeah, well, that would allow people to just not fill it out, I guess, like to submit that they didn't complete it. But I thought we were saying earlier that you would still complete it even if they have a CDR of greater than 1. You just would have that information and then be able to pull the data if you didn't want to use it for those participants.
Okay. So we're changing, okay, any CDR, you can give it to them. I mean, use your discretion. Obviously, a CDR of 2 or 3 is the person's gonna be really frustrated. So try to use your discretion, your clinical judgment, I guess.
And we'll try to work on clarifying that in the instructions. As
Yeah. Yes, so you need us to submit it for everyone. Yes, everyone. I'm assuming you mean all populations and not just all CDRs, but these should be gathered in every person, regardless of their identity. And now we're saying regardless of their CDR. I think a 2 or 3 would be kind of hard though, because it's self-administered. But if you don't know what their status is when you're giving it to them, then just do your best and we will sort it out once we get the data in. Okay, Megan, that's a question for you.
Yeah, that's a good question. So the question is, are any items on the social determinants of health module actionable? For example, if a participant indicates that they don't feel safe in their home or neighborhood. I mean, this is the eternal question here. I think that we don't distinguish in terms of neighborhood why they don't feel safe. So, you know, we know that as people age, they might feel unsafe in their neighborhood just because they cannot get across the street in time, you know, with the traffic light, or there is not sidewalks or something like that. It could just be a problem like that. We don't really know. With a lot of centers now are moving toward having a social worker embedded in the center. And I do think that if someone indicates that they don't feel safe in their home, you know, that would be something for the clinicians in the space to follow up on. We, you know, I think we want someone to understand why that's happening, but these were not meant to be screening questions. They're more meant to get at, you know, if a given health behavior stops, or changes, you know, what could be the determinant of that? What are the barriers there?
Okay,
Dr.
thank you.
Barnes, anything you want to add?
No, I think that's good. And I think, you know, in healthcare in general, they are moving more towards assessing social determinants of health. So this is something that I don't think we can continue to hide from, and we just need to be ready to address it. And we are one of the centers who has a social worker. So we have participants that do not know how to write. Does the coordinator administer the forms? Yes, in that case, please have someone from your center, coordinator, research assistant, administer the form.